right, great. Thanks, Michelle, for offering to drive for me today. I'm having technical issues. But today we're going to talk about kidney transplantation in the elderly and when is old too old. I'm not going to go through organ allocation and things like that as they apply to the elderly and outcomes. But really, I was more interested in looking at how we as physicians can evaluate our elderly patients in determining whether they're appropriate for transplantation or even referral to transplantation. Next. Let's start with the illustrative case of Mr. S, who's a 68-year-old man from Wyoming who has end-stage renal disease due to polycystic kidney disease. He's been on home hemo for about 3 years, and he presents for his first pre-transplant eval. His past medical history is significant for diabetes type 2. It's fairly well controlled with an A1C of 7. No history of coronary disease or malignancy or smoking or pulmonary disease. These are all the things that we look at very closely as we're doing pre-transplant evaluation. Mr. S doesn't engage in formal exercise. He's mostly sedentary, but he does go fishing in the summer. His 65-year-old wife accompanies him and provides much of the history since she co-manages most aspects of his care. They report that home hemo is going very well, actually. He doesn't have any problems with volume issues, no weight loss. He has a good appetite and really a decent sense of overall well-being. However, what they found is that the time commitment of home hemo is becoming burdensome, and he'd like to know if a kidney transplantation is for him. Next. So this is USRDS data that basically shows, if you look at the light green and the light blue lines, those are all our elderly patients over 65 years of age. They comprise far more than 50% of the incident ESRD cases in this country and in most developed countries. These are the population that you're going to be seeing, that we see most frequently starting dialysis in today's time. Next. Despite comprising over 50% of incident ESRD cases, the elderly comprise only about 20% of annual kidney transplant recipients. So the question here is our hesitation to refer and to transplant justified, or could we be doing a better job vetting these patients and identifying those who are appropriate candidates and transplanting them more? That's really the key question here. Next. So this is data again from USRDS, and it looks at the amount of dollars per patient per year that is expended according to dialysis modality. So for hemodialysis, that's a dark blue line. The average hemodialysis patient costs, in terms of hemodialysis and all surrounding associated costs CMS about $90,000 a year. PD is about $12,000 to $15,000 cheaper per year, and transplant is substantially cheaper at just north of maybe $35,000 a year. So you look at this and you can see where the numbers are. You would be saving somewhere between $35,000 and $55,000 a year per patient per year with transplantation. That's a lot of patients. The US, I think, has somewhere between 500,000 and 600,000 ESRD patients. So the money really adds up. And so it doesn't take a leap of logic to understand that the elderly are going to comprise a large fraction of this potential savings from the perspective of the government. Next. So this understanding that transplantation and home dialysis, but more transplantation, is a huge cost savings opportunity. The federal government issued what's called the Advancing American Kidney Health Initiative, also called the Presidential Executive Order, July 2019. And there are several goals in this executive order, but the primary goal was to have 80% of new end-stage kidney disease patients in 2025 either receiving dialysis at home or receiving a transplantation. Now, obviously, this goal will not be met because it's already 2022. So And there's no way we're near that goal. But what this executive order resulted in was what's called the ESRD treatment choices model. And in this treatment choices model, dialysis providers, both the large dialysis organization as well as individual providers, are financially incentivized to increase their population of transplants or referrals to transplants. And so built into their reimbursement model is what fraction of your patient population has been transplanted or is waitlisted. And so what that means is we're, again, going to be seeing more and more elderly people referred to us for transplantation. Next. So the conundrum, compared to dialysis, transplantation offers greater survival, improved quality of life, and is a lot cheaper. And these are all facts. They've been established for the general population. Okay, but unlike dialysis, transplantation is a finite resource. You can argue dialysis isn't, but it's certainly treated, dialysis is treated as an infinite resource in this country, as Shrey alluded to last week. The typical elderly end-stage renal disease patient has very limited survival. So how much marginal benefit does transplantation offer in terms of longevity and complications, in terms of quality of life? Is there an age cutoff? And I'll answer that question right now. There isn't an age cutoff. Most developed countries also do not have age cutoffs. Transplant programs are kind of expected to vet each patient individually and determine based on their unique circumstances whether or not they are candidates for dialysis, no matter their age. We do a great job assessing for cardiovascular, pulmonary, metabolic, malignancy risk. We even have social workers and nutritionists evaluate patients in the pre-transplant setting. But what else might we consider pre-transplantation to optimize candidate selection? Because what's obvious in this age group, over 65, phenotypic variation is huge, right? I mean, there can be huge differences between the health, frailty, as we'll go through later, in those that are over 65 years of age, because they have 65 years of history, of medical history behind them, and that can lend to huge variations between individuals. Next. This just all kind of puts it all into perspective for me. I think for most nephrologists who've spent a lot of time taking care of the elderly, and with respect to end-stage renal disease, the one-year mortality rate in adults over 65 years of age, and this is the general over 65 years of age, initiating dialysis is 30 to 55%. That's huge, right? That's huge. And that gives you kind of a baseline perspective on the population that you're dealing with in general. But what I'll remind everyone is that the waitlisted elderly population, they've been vetted in the pre-transplant clinic. Comorbidities have been extensively evaluated. They're obviously a lot healthier than the elderly general dialysis population. Next. So just as the elderly comprise 20% of transplanted patients, the elderly also comprise 20% of waitlisted patients, and that is in this light blue line here. Next. And not surprisingly, the elderly also have the highest mortality rate among the waitlisted, and again, that's the light blue line. Next. So this is kind of a seminal paper. It was published in '99 by Wolf et al. Out of the University of Michigan, Ann Arbor. And they were really interested to understand what kind of survival benefit does transplantation offer. And they divided up their patients. This was what they did was they used the ESRDS data to compare survival in 23,000 transplant recipients of deceased donor kidneys to 46,000 waitlisted patients. And the waitlisted patients were their reference group, not the general dialysis patient, but the waitlisted, because they should theoretically be physiologically equivalent to those who are transplanted. And what they found was that if you look in I just marked the 60 to 74 year group, there's a 61% 18-month survival benefit in this population. And if you look at the far right two columns, the projected life years in those who are waitlisted was 6 years versus 10 years for those who've been transplanted. So that's a marginal life year gain of 4 years, right? That's on top of whatever you would get with dialysis. So 4 years, 4 to 5 years has kind of been what I've seen repeated over and over again in the literature, is the marginal life year gain with dialysis in the elderly. But that's with a huge caveat of the 1 year mark. 369 days is the point at which the elderly who are transplanted, their likelihood of survival equals that of the waitlisted group. So that first year after transplant is really tumultuous for the elderly. And it takes them literally a year before their likelihood of survival equals and then subsequently exceeds those who are just waitlisted and getting dialysis. Next. This paper was not as optimistic in terms of survival for the elderly. This paper looked at those who are transplanted and divided up their patient population into two groups. That is, those who are transplanted 2 years after starting dialysis and those who are transplanted 4 years after starting dialysis. And if you look to the very far right section with the 65 plus, in those who are 65 years or older who get transplanted after 4 years of starting dialysis, it didn't matter what kind of kidney you got. There didn't seem to be a significant survival benefit over maintenance dialysis. But then if you took the elderly population and transplanted soon thereafter, after starting dialysis within 2 years, then there was a substantial is a relative term, but there was a survival benefit if the elderly received, especially if they received a living donor transplant. That's the white bar there in the 65 age range. So the lesson here was, if you have an elderly person with stage 4 or 5 CKD or just starting dialysis, then if you want them to garner survival benefit from transplantation, you got to refer them as soon as possible. And on top, and if once they're referred, they really should get a living donor transplant. If they don't have a living donor, then they should really even take an extended criteria donor within the 2 years, instead of waiting and waiting and waiting for that standard donor, the deceased donor transplant, and then garnering no survival benefit at that 4 year mark, right? So that's kind of the lesson here that I took from this. Next. So let's talk about death-censored survival benefits. So if you look at how grafts survive in the elderly, in the overall population, unsurprisingly, 60% of transplant patients, so we'll look at the left graft first. In those who are under 50, let's see, so 60% of transplants survive at 8 years if you're under 50. Now, if you're over 60 and really over 65 years, you're really only looking at about a 31 to 43% transplant survival at 8 years. But these numbers completely change if you do a death-censored graft survival. What that means is if you look at graft survival, but you knock out all the patients that died with a functioning graft, surprisingly, the elderly have just as good a graft survival as do the younger. And in fact, at various time points, and now I'm looking at the graph on the right, at 1, 3, 5, 8, and 8 years, graft survival is really comparable and sometimes even better than the younger groups. Okay, and so what that tells you is that the elderly are dying with functioning grafts. Okay, next. And in fact, this is from the same paper and they just summarized the data differently. the elderly have a 3 times, and these are the blue boxes there, 3 times the likelihood of dying with a functioning graft than younger recipients, okay, the 20.6% versus 61.3%. But the opposite is true with respect to immunological failures. That is, the younger population are more likely to experience acute and chronic rejection, 2.5 times more likely than the elderly population, which is the 16.1%. Okay, so, and it's thought that this lower likelihood of developing immunological failure in the elderly is due to what's called immunosenescence. Next. So immunosenescence, the same thing that confers protection against rejection in the elderly, is ironically the same issue that predisposes them to infection. And this is a study published by Bruce Kaplan and again, the group out of, I believe, Ann Arbor in 2001. They looked at the rates of infection in transplanted patients versus those who are waitlisted. And what they found was that the risk of infection not only increases as you get older, it increases exponentially in transplanted patients as you get older. So the risk of having an infection-related death is exponentially higher in those who are older, 60, 65 plus. Okay, next. Bruce Kaplan's group also found that cardiovascular disease is the most common cause of death in the elderly renal transplant recipients. And again, looking at the dark bars here, there is really kind of a constant slope such that there is a constant age-associated increase in the risk of dying from a cardiovascular event. But if you look at the risk in those who are waitlisted, the risk is higher. So it's as if while the elderly still have an age-associated increase in cardiovascular death, if you're waitlisted, your risk of cardiovascular death is even higher. So at a minimum, in this case, transplantation offers cardiovascular protective effects in those who are transplanted. Next. So we talked about the marginal life years gained, 4 to 5 years on top of whatever your baseline would be with dialysis. The fact that the elderly die more often than not, I think 60% of them die with a functioning graft. And the fact that their most common cause of death is cardiovascular and infection causes. What about quality of life in the elderly? The quality in the elderly who get transplanted. Quality of life is in the literature most often measured with a tool called the medical outcome study short form, or short form 36. It's a proprietary tool. It's commercially available for those who are interested in doing research with it. And it's based on 8 scale scores, which are the weighted sums of the questions within each section. And the 8 sections are vitality, physical functioning, bodily pain, general health, role limitations due to physical and emotional problems, social role functioning, and mental health. These are the 8 components of the SF-36. And each scale is directly transformed into a 0 to 100 scale. And so the higher the score, the less the disability. Okay, so that's just a little background on the SF-36 and the quality of life testing. Next. So as I did research, kind of try to look for papers that definitively argued that there's a substantial quality of life benefit in the elderly who get transplanted, I wasn't really able to find anything. Okay, but this paper did a pretty good job summarizing those individual papers. And what you'll find is that in Ribolo et al., for instance, the first paper that's listed here, he was able to show, again, using the SF-36 domains, he was able to show that there is, compared to dialysis patients, the transplanted elderly patients do experience do experience an increase in physical functioning, sense of general health, bodily pain, vitality. But the other papers that, for instance, if you look at quality of life compared to those younger transplanted patients, there really wasn't a substantial improvement in overall sense of well-being. There was some increase in vitality and some increase in mental health. And then if other papers looked at quality of life scores compared to national norms, and those were, again, a very mixed bag, but I would argue that no paper has really consistently been able to show that overall quality of life is improved when even compared to national norms. And I guess the real way to have done any of these studies would have been to compare quality of lives in transplanted elderly patients with their waitlisted counterparts. But that, as far as I can tell, has not been done. So the jury is out on this. I think if you're going to argue substantially improved quality of life, you're really going to have to pick your elderly candidates very carefully and map out their phenotype in such a way that you can say with some degree of confidence that quality of life will be improved, just as their longevity would be. Next. So a thorough pre-transplant evaluation should, in theory, be able to predict who will do well post-transplant and who will not, both in terms of survival and quality of life. There are no widely used predictive tools to assess transplant candidacy in the elderly. Predictive elements that are often not formally quantified in the pre-transplant evaluation are elements that are becoming increasingly talked about in the literature. They are physical function, cognitive function, and frailty. And we'll go through each element very quickly since there isn't a lot written on it, but I think they merit some attention. Next. So again, physical function, it has been quantified in papers using the short form 36, just the physical functioning component domain of the short form 36. And that includes physical fitness, sensory function, and ability to negotiate the external environment. Next. And this paper looked at basically linked UNOS registry data about post-transplant survival with pre-transplant functional status. And they basically looked at almost 11,000 patients in 212 transplant centers. The mean age was 50 years of age, but 14% of the patients were over 65 years of age. And what they did was they divided up functional status into quartiles: highest, near highest, lowest, and near lowest. And these are, again, all pre-transplant functional status quartiles. And they looked at survival after transplantation based according to these quartiles. Next. And what they found was that across, in general, in the general population, those who had the lowest functional status, physical functional status, had the highest mortality or the lowest survival. Okay, and that's not surprising. Next. And if you divided up the patients according to age, the oldest ones, those over 65 years of age in the very right hand side of this graph, those with the lowest function had a substantially increased mortality compared to those with the highest function. So again, not a surprise. The elderly are particularly sensitive to their functional status and their survival post-transplantation. Next. What about cognition? We don't really consistently measure cognitive function in the pre-transplant evaluation. Dementia, we know, is a relative contraindication for transplantation. I think most transplant centers would be loath to transplant anybody with obvious dementia, but there are really no guidelines for evaluating cognitive impairment in transplant candidates. And I'll remind everybody, and this is especially important because patients will have cognitive impairment and not necessarily fulfill the diagnostic criteria for dementia, right? So dementia, I'll remind everybody, is an acquired cognitive impairment that has become so severe that it compromises social and occupational functioning. It is associated with an elevated risk of graft loss and mortality in older adults following kidney transplantation. But what is cognitive impairment? cognitive impairment is a state intermediate between normal cognition and dementia. And it's associated in the general community dwelling geriatric population with an increased risk of mortality, hospitalization, ICU admissions. It also increases in prevalence as the severity of kidney function, as kidney function declines. So the worse your kidney function, the greater the prevalence of cognitive impairment. And ESRD patients have twice the prevalence of moderate to severe cognitive impairment as the general population. And cognitive impairment in dialysis patients has been independently associated with an elevated risk of mortality. So what effect does cognitive impairment have on kidney transplant recipients? Next. So this paper looked at the modified mini mental state exam, the 3MS examination, to measure global cognitive function right prior to kidney transplant. So patients would get admitted for a kidney transplant, hospital admission, and then they would do the 3MS scoring beforehand. And it was a prospective study of 864 kidney transplant recipients. And they basically looked at the relationship between pre-transplant cognitive impairment and all-cause graft loss. Next. And what they found was that in this general population, the overall prevalence of cognitive impairment was 6.6% in the living donor kidney transplant recipients, and just north of 12% in the deceased donor kidney transplant recipients. This is, severe plus mild impairment. Next. And what I want to focus on here are the two graphs that are diagonal from each other that have the light blue boxes. And what they found was that I'm going to look at this. What they found was that there was a substantial increase in the living donor kidney transplant recipients. If there's any cognitive impairment at all, at the 5-year mark, there was a substantial increase in all-cause graft loss. And really, in the deceased donor kidney transplant recipients, they found a substantial increase in all-cause graft loss in those who are severely cognitively impaired. And again, this is not obvious dementia. This is severe cognitive impairment that you would only catch by doing the appropriate studies. Next. So the final element is frailty, that is measured most commonly with the Fried frailty phenotype. Frailty is sort of it's an abstract concept that is certainly has had a lot of traction in the geriatric literature, but it's also gaining a lot of traction in other areas of medicine. Frailty is a measure of physiologic reserve. Okay, it's how well can a patient bounce back from trauma of any type, whether it's surgical or medical or otherwise. It's distinct from comorbidity, disability, and cognitive impairment. And it does confer a high risk of mortality, falls, disability, and hospitalization. It's been very well validated, this concept of frailty, and especially this phenotype measurement. It's been very well validated in geriatric populations and in ESRD population. And it's emerging as an important risk factor in surgical patients and transplant recipients. And frailty is basically based on 5 components, each scored 0 for absence and 1 for presence. The 5 components are shrinking, weakness, exhaustion, low activity levels is measured by how many kilocalories you expend a week, and slowed walking speed. And with this next study that I'll go through, non-frail is scored for anything 0 to 1. Intermediate frailty is a score of 2, and frailty is a score of 3 or higher. Next. And what they found was, not surprisingly, again, those who are frail, and that's the dark line, at 5-year mark, have the lowest survival, a difference of almost 20 to 30% compared to those who are non-frail at all. Okay, next. And frailty particularly seems to affect who are 65 years of age or older. The 1, 3, and 5 year mark in those who are frail, those elderly who are frail, have a substantially lower survival than those who are not frail in the same age group. Next. So back to the illustrative case, Mr. S is a 68-year-old man from Wyoming with polycystic kidney disease on home hemo for 3 years. He has type 2 diabetes for many years, A1C of 7, doesn't really have any other major comorbidities, but he's not very active, right? Which makes you wonder what his physical functioning is that can in the end affect his post-transplant outcome. He's very dependent on his wife, who is, by the way, 65. She's not very young either. And that makes you wonder about his cognitive function and his frailty. And these are all elements that we don't really measure, that we don't capture or formally measure in the pre-transplant setting. And then finally, what I want to emphasize is that he feels great on home hemodialysis. And so, yes, I think with a fair amount of certainty, we can offer this guy marginal survival of who knows how many years, maybe 4 or 5, maybe a little bit more years on top of what dialysis would offer. But I'm not sure that we can, with a fair amount of certainty, offer him a substantially improved quality of life, especially since he feels so well on home hemodialysis. And so the question is, would you offer him a kidney transplant? And I think as things stand now, with the metrics that we use in terms of measuring comorbidity, having social work weigh in, having nutrition weigh in, and surgery weigh in, we would offer this fellow dialysis or a transplantation purely on the basis that we'd be fairly comfortable that his survival would be improved. And we would hope that along with that would come some improvement in quality of life as well. But I'm not sure that the literature really supports that position. Next. So summary, transplantation for those older than 65 years of age. Survival's improved by 4 to 5 years with transplantation, but the risk of death is greater than waitlisting that first year post-transplant. Most grafts outlive their recipients. Death with a functioning graft is the commonest cause of graft failure in those above 65. The most common cause of death in this age group is cardiac disease and infection. And improvement in quality of life with transplantation is highly variable. And I'll leave it at that. It's therefore, I think, likely dependent on pre-transplant characteristics. There are no clear age cutoffs for transplantation, but pre-transplantation phenotypes such as physical functioning, cognitive functioning, and frailty, I think really merit a lot closer look. And that's it.
Thank you, Monita. That was very nice. I have a quick question. Obviously, all the data that you presented is pre-COVID, and this is probably a tough question because we don't have a lot of data. But I'm just going from what we know. We know that COVID has affected the spectrum of patients with kidney disease, but it has affected more profoundly the transplant population despite vaccination. Knowing what we know about COVID and age being a risk factor, immunosuppression being a risk factor, would your recommendation change for this 68-year-old?
Yeah, I can say that our recommendations haven't changed. We are, and it's ironic because I think a recent paper came out that looked at the protective benefits of vaccines in those who are over 50 years of age who get transplanted. Mm-hmm. And the protective benefits are marginal to none in terms of survival. So if you're under 50, you do garner some protective benefits, but if you're over 50 and you're transplanted, then the vaccine tends to not be as effective as we would have thought. But I think in practice, we are continuing to offer the elderly transplantation, kind of irrespective of what's going on with COVID and the vaccine.
Thanks, Monita.
Monita, it's Isaac. Hi. I enjoyed that very much. Thank you. I have a a comment, I guess, a comment question. You know, there's this old nursery rhyme. When she was good, she was very, very good. And when she was bad, she was horrid. That describes my experience with my elderly patients. And I'm talking above age 75 now. 68 is still young. People above age 75 who are going to transplant. I've seen some do incredibly well, who enjoy a superior quality of life. They can travel, they can do stuff that they couldn't do on dialysis. And then I've seen disasters, people either dying or spending months in the hospital, horrific outcomes. Is there a way, taking into account all the things you've discussed, the cognitive abilities, the degree of frailty, and come up with some sort of a composite score that predicts who's going to have the better outcome and should be transplanted versus the others?
Yeah, that's really, you know, the $1 million question. There are, Johns Hopkins is working on that. In fact, Johns Hopkins has done an amazing job creating calculators for every clinical scenario you can think of with transplantation. But I believe Johns Hopkins is working on that very same thing. There are some, there is a program, I think in Sweden, in Europe, that is developed an assay or sort of a list of profiles that would help better calculate post-transplant outcomes. But I guess the short answer is currently there isn't a single one that is being used. Several that are being deployed and tested in various transplant centers, but not single one that is sort of standard of care right now. But yeah, you're right. What you just described was frailty by definition. I mean, it's the elderly are at that age where, and that's what worries me, is that these patients come into the pre-transplant clinic and they look great. Just as the example that I provided, by every standard metric of comorbidities, you know, as internists, we're good at, oh, cardiovascular disease, pulmonary, let's quantify it, let's blah, 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 blah. All of the boxes mark off, they check off, and look, this is a 70-year-old patient, he looks great, let's transplant him. But what we really haven't done, the finer phenotyping and defining these patients in finer ways that apply to geriatric populations that may not as heavily apply to the rest of the population. Because the geriatric body truly, truly, truly is a very different body from the others. They just are physiologically. And I'm sure a geriatrician could speak to that more thoroughly. But I do feel like as nephrologists, we're just not as sensitive to that reality, even though the large majority of our patients are geriatric.
I'd just like to share some of the experience with our older PKD patients. So, in fact, a lot of them I've had transplanted around age 70, and they've got preemptive transplants. So at GFRs of 20, and the transplant has told me, well, the kidney's going to last 20 years, so it'll last them the rest of your life. So the question is, if you do the transplant preemptively rather than waiting till they're, crash 2 years on dialysis, would that be better in elderly patients?
I think that would be better for any patient, but I think definitely the elderly would definitely garner quite a lot of benefit. And I would even go so far as to say, I bet if we did this study, even their quality of life would be substantially improved, like categorically. But again, it's that elderly, 70-year-old who's stage 4.5, 5 CKD, he didn't get there overnight. So he's accumulated his physical functioning, his cognitive functioning, my bet is his frailty probably did climb exponentially during those few years. And so the question is, I guess I couldn't say with a fair amount of certainty that he would necessarily do better without having better measuring tools.
Great.
Monita, yeah, still here, very quick, Monita. Is there any data on race and who gets transplanted over 65, part 1 and part 2? Is there any data that African Americans do better, worse, or indifferent after age 65 if they're transplanted?
I don't think that data exists, but I can tell you, I'm sure just as African Americans are underrepresented in the general population in terms of access to transplant, I'm sure they're definitely underrepresented in the elderly population. But in terms of outcome, I'm not sure that that data exists. At least I haven't seen it.
Thanks. Go ahead, Anil.
One question. So going back to your original question, that how old is too old, and the data you presented that the 70 to 74-year-old only gets 1 extra year. So what's the answer? How
I know,
old-
right? No, I mean, it's, let me tell you, I don't want to step on a landmine here, but my professional experience with the elderly has, I personally would not recommend it, especially if their quality of life is reasonable right now. I couldn't.
James, do you have a comment?
I do. Sorry, I missed most of this. I've been in clinic. Monita, I'm sure, was excellent. As Monita, I'm sure, showed you the survival data for patients over the age of 70 after transplant is, it's pretty equivocal. There might be a slight survival benefit. There's a definite survival benefit from a population standpoint if they have a living donor as opposed to a deceased donor. Monita, did you have the guild
Yeah.
paper up? And
Yeah.
So the conversation that I generally have with patients who are over 70 when they're here for evaluation is that with transplant, it's unlikely that we're going to prolong your life. The main motivation for doing this would be to improve your quality of life or to sustain your quality of life. And I try to get patients to understand sort of that concept. And so I don't think anyone can say that we shouldn't transplant people for quality of life alone. I think that's a very good reason to transplant people. And so, as Monita said, a lot depends on what their quality of life is like at baseline and how much we think we might be able to improve it with transplant. And so, if somebody's on PD, they've been on PD for a year, they are happy, they're able to travel, see their children, do whatever they want to do. I have a serious conversation about, why do you want to take the risk with transplant? Your life is good. We can't necessarily improve that. And then you have somebody who's, on hemodialysis and can't travel, can't do what they want. They're miserable. They're otherwise, healthy enough, in our opinion, to have a reasonable chance of succeeding with transplant. That's a very different story, and it might be much more worth it to go for it in that situation. So I think, for that reason, we always say we don't have an age cutoff in transplant. You just need to start looking at what are the relative benefits that the patients expect, that we would hope the patient could get at that age. And it's not as clear cut as in younger patients. Sorry, that was kind of a long-winded answer. Hope that made sense.
Thanks. Yeah, I mean, the question that comes up is if somebody does not have a living donor and they are above 70, then should we be referring them at all? Because that means they're going to be on the waiting list for several years on dialysis. And that's always the dilemma, that if they don't have a living donor, if they have a living donor, then yes, maybe, but what if they don't have a living donor?
Yeah, it's definitely more difficult without a living donor. Like you said, there's waiting time. And as we know, especially patients on dialysis, when you're over 70, your mortality on dialysis is very high. And so those cases we take, on a case-by-case basis. And if we think the patient is healthy enough to be able to tolerate, a quote unquote more marginal kidney, higher KDPI kidney, a kidney that's got higher chance of delayed graft function, we can oftentimes get patients those kidneys significantly faster than if they were to be waiting on the waiting list for a standard criteria kidney. And so again, it kind of depends on the case. You know, somebody's 72, they're still, you know, exercising, they're active, they don't have a lot of comorbidities. It might be very reasonable to have them on the wait list for, you know, knowing that they might wait for 2 or 3 years and that they might very well still be healthy enough for a transplant at that point. We definitely set the expectation that they're going to see us every 6 to 12 months while they're on the wait list, and at any time something may happen where they're no longer a transplant candidate, so that doesn't come as too much of a surprise if it happens. But then, you know, somebody who's 76 and they're diabetic and they have, you know, they got a stent placed 3 or 4 years ago and they can walk a block or two, but they're not that active. You know, that's a different case. And then we start to say, well, you know, the chance that that person's going to be able to wait for even 2 or 3 years on the short end is extremely low, and probably, you know, we'll counsel them differently. But always best for a patient to have, I mean, regardless of the age, always best to have a living donor for multiple reasons.
James, do you know there? I understand there is a new paper that at least it's been accepted in a high impact journal looking at this same question. Have you seen or have you heard anything about it? Just showing that survival of that, comparing survival of dialysis patients and transplant patients, pretty much is, according to this, what the data is showing, that is very similar after the age of 65.
After the age of 65, yeah.
I understand it's coming out in the New England Journal of Medicine, but
Interesting.
I have not seen.
I'm not aware. Yeah, I'm not aware of that. It sounds, you know, similar to the data that we've had, you know, even going back to the Wolf study that
Back in
published in the
1999.
New England Journal in '99 that showed minimal benefit. I'm glad that, you know, I've thought for years that we need updated data on that since we're a couple decades deep from that original paper.
Yeah,
I'll keep an eye out for that. I haven't seen the results.
well, Monita, thank you so much.
Yeah, thanks.
Grand question, great grand rounds.
Thank you.
Yeah.
Thank you, Monita. That was awesome.
Thanks, guys.